We're going to briefly review some topics in psoriatic arthritis. First, we'll look at what to do when anti-TNF treatments fail and which patient profiles might be suitable for an anti-IL-17 inhibitor, an anti-IL-23, or an anti-JAK inhibitor. We'll also look at the patient profile for treatment with apremilast. And once we've finally achieved remission, what do we do then? Do we reduce or discontinue the biologic treatment? Well, when there has been an anti-TNF failure, ideally we shouldn't leave it up to rock, paper, scissors. We should try to find the best possible treatment for our patient. The causes of anti-TNF failure are mainly primary failure and secondary failure. Primary failure mainly occurs in, let's say, several situations where there is indeed actually a high inflammatory burden where the disease is truly active. It may not be dependent on anti-TNF, in which case we're targeting the wrong pathway, or there may be genetic and molecular factors at play that today we are not able to identify in our clinical practice. When we move into secondary failure, it's that patient who initially responded to the treatment, but we see that progressively the effect is being lost. It could be that the patient is developing anti-drug antibodies. These antibodies can either neutralize the drug or accelerate its elimination. And this has been described both in antibodies and in treatments that are based on chimeric molecules. Drugs like infliximab, which are 25% of murine origin, where such cases have been reported, with many autoantibodies against the drug, but also even against molecules that are fully human. The fact that there are patients who test positive for those autoantibodies against the drug doesn't necessarily mean that the drug is no longer working, because periods of immunological tolerance have also been described. Therefore, the recommended approach would be to test for these autoantibodies when we suspect that the treatment is failing. It has also been observed that in relation to monotherapy, patients who, for example, are on anti-TNF monotherapy may more easily develop this loss, this secondary failure due to autoantibodies against the drug. That's why it is usually recommended to combine it with certain immunosuppressants such as methotrexate. On the other hand, secondary failure can also occur due to disease progression, in which other factors may once again be playing a role. Pathways that initially were not playing a role. And changes in the patient's weight and metabolism are also important because in the end, they will alter the drug's pharmacokinetics, and this can result in drug concentrations not being sufficient in that situation. And of course, poor adherence, asking the patient how, when, and where they are administering the medication. If the treatments are intravenous, then that's something we won't miss. But it wouldn't be the first time a patient is on a treatment subcutaneous and is not administering it properly, removing it before it has been fully delivered. So that also needs to be taken into account, and even observing how the medication is being administered. Anti-TNF drugs can also fail due to adverse effects. There may be infections ranging from mild pharyngitis, sinusitis, to more serious infections like pneumonia or reactivation of latent infections. It is very important to perform tuberculosis screening in all patients who are going to start biological treatment, assess the patient's vaccination status, refer them to preventive care if that option is available in our hospital, and ensure that all pending vaccinations are updated before starting treatment. Local or infusion-related reactions are classically well known, especially at the beginning of some of the therapies we use. There can also be hematological alterations, various forms of leukopenia, neutropenia, even pancytopenia, which need to be monitored through blood tests, dermatological issues, and even the development of paradoxical psoriasis with the initiation of certain medications. And the risk of neoplasia and lymphoma is something that always has been discussed. And it's not very clear whether it's truly a situation caused by the chronic inflammatory disease itself that the patient already has. Yes. But it seems that, for example, diseases, dermatological diseases such as basal cell carcinomas and others may indeed be more closely related to these drugs. autoimmune events such as lupus-like syndromes before starting an anti-TNF treatment or other biologics, ideally we should have a prior assessment of ANA, even if we don't suspect anti-nuclear antibodies, even if we don't suspect that our patient has, for example, lupus, and we're very certain it's rheumatoid arthritis. Well, we should have that assessment because if they later turn positive, it can help us a bit to determine whether it's truly a reaction to the drug or if the patient was already carrying this condition and it had gone unnoticed. Cardiovascular events. Well, with patients on anti-TNF therapy, we also need to carry out cardiological monitoring. Keep in mind that in cases of decompensated heart failure, the use of these treatments would not be recommended. However, if the heart failure is under control, this would not be a contraindication. And what could we do? Can we intervene to reduce those adverse effects from anti-TNF? Well, I brought this systematic review here, which showed that 20% of patients discontinued their first cycle of anti-TNF therapy, and that this percentage increased over time, and that the main reasons for discontinuing the drug were a lack or loss of efficacy, or even that remission of the disease was achieved. Adverse events were also a key reason for discontinuing these drugs, as well as patient preference, which also plays an important role. In the end, this can lead to a lack of adherence, and comorbidities that may be related can also influence the patient's decision to stop the medication. This systematic review in this study conducted a comparison of the incidence of infections and skin manifestations in patients when reducing the dose of anti-TNF drugs, and just to briefly mention, it did not show a reduction in adverse effects related to infections or skin reactions when lowering the amount of treatment. And while we find ourselves in this situation where we have various drugs that we can offer to our patients with psoriatic arthritis in cases of anti-TNF failure, so what do? There are many pathways we can take. Let's do a very brief review to clarify whether in this situation where anti-TNF has failed, there is any strong recommendation or guidance, something very clear that we need to do when the first anti-TNF treatment has failed, which is the fundamental question of this topic. In the year 2018, the guidelines from the ACR and the National Psoriasis Foundation set forth two main branches of focus: patients who were on anti-TNF monotherapy and patients who were on anti-TNF combined with methotrexate. In this situation, we see that there are three main branches. Let me see if I can use this. Yes, sorry. Three main branches, and well, in the case of anti-TNF monotherapy failure, they give preference to another anti-TNF over IL-17, IL-12-23, abatacept, tofacitinib, or even adding methotrexate in this situation, with the exception of certain cases. Mentioning this is mainly because even if it's a low or very low grade of recommendation, it's just to help us see that here they are recommending the use of anti-IL-17 or anti-IL-12-23 if there is severe psoriasis. It doesn't matter the previous preference. If the patient prefers less frequent drug administration or there is concomitant inflammatory disease, in this situation they give preference to IL-12-23, to abatacept in cases of recurrent or severe infections, to tofacitinib, and upadacitinib is not mentioned because at that time it was not yet available on the market. If the patient has a preference for oral therapy or concomitant inflammatory disease, here they do recommend adding methotrexate if a partial response has been observed to the current anti-TNF therapy. Therefore, in conclusion, for patients who are on anti-TNF monotherapy, this is the preference list: anti-TNF above the rest, IL-17 above the rest, or anti-IL-12-23 above the rest, except in these circumstances. And when we move on to patients who start with a treatment of anti-TNF and methotrexate, in short, they recommend continuing methotrexate if the drug previously used was an anti-TNF, or also in cases of severe psoriasis with a partial response to the current treatment with methotrexate, or in the presence of concomitant uveitis. They advocate for continuing with monotherapy, even if the patient was previously on anti-TNF and methotrexate, to proceed with monotherapy using IL-17 or IL-12/23. Although they say that methotrexate can be continued until a certain level of disease control is achieved with the appropriate treatment. This is according to the 2018 guidelines, 1010 and 2000, which are outdated, but still, they are the ones that take a bit more of a stand in establishing a preference, though, as I said, with a rather low level of evidence. When we look at the GRAPPA guidelines very briefly, we know that here the degree of involvement by domains, let's say, they recommend, depending on the affected domain, what to do. And in the situation that concerns us when anti-TNF therapy has failed, we're no longer at this point, but rather here, then we realize that indeed they do not establish any priority among the different drugs. And they also mention the importance of taking comorbidities and other associated diseases into account when making a treatment choice. The EULAR guideline, once we've gone through the entire algorithm of glucocorticoids, methotrexate, sulfasalazine, and we've already started biological treatment, and it has failed. So we're now in this situation again. They also don't establish a specific priority. They suggest switching to another biological treatment, and here they already include abatacept and or JAK inhibitors. As we know, the treatment branches vary depending on whether we're dealing with arthritis, enthesitis, or predominantly axial involvement. Here as well, they make that prioritization based on the most relevant musculoskeletal and non-musculoskeletal manifestations. So after an initial failure with anti-TNF, what would be the next step? Well, the most recent recommendation, according to EULAR 2023, is to switch. Even a switch is considered without specific guidance post-anti-TNF failure. They recommend choosing based on extra musculoskeletal manifestations. In the GRAPPA 2021 guidelines, there is also not enough data to make recommendations regarding which treatment to follow after anti-TNF failure, but it's also important to consider the patient's comorbidities and associated conditions. And in the older ACR-MPF 2018 guideline, they do take more of a stance and give some preference if anti-TNF failure was used as monotherapy or in combination with methotrexate. However, we should note the quality of evidence is low or very low, and they also recommend tailoring to the clinical situation.